Hi, my name is Heidi Hazy, and I'm a DNP student at Palm Beach Atlantic University. Today I will be presenting a case presentation on cerumen impaction. The patient presents today with complaints of "my left ear hurts really bad." BH is a 19-year-old male who presents with complaints of left ear pain. He states that he has been having this ear pain for a few weeks now, but before 3 days ago it would go right away. However, the last few days is constant 8 out of 10 throbbing ear pain to his left inner ear. He denies any trauma, fevers, chills, fatigue, or drainage from the ear. He states that there is no time of day where the pain is better or worse, but that when he lays on that side, the pressure can be a little more than while sitting up. He has tried cleaning his ear with a cotton tip applicator and says he got some earwax out, but I feel like there's more in there. He denies swimming recently or riding on a plane. He also denies any scuba diving or free diving recently, although he does free dive. He has not been in months because of the pain. The patient has no past medical history. The only surgery that he has had are the 2 surgeries listed: the surgery to correct his pyloric stenosis when he was a few weeks old, and an ORIF to the left arm when he was 10 years old. The patient lives at home with his parents. He recently graduated Palm Beach Gardens High School and will attend Palm Beach State College in the fall to become a firefighter-paramedic. He denies the use of tobacco, alcohol, or illicit drug use. He is sexually active and uses condoms as his form of birth control. His father is alive and is 62 years old. Medical history of hypertension, diabetes, and hyperlipidemia. His mother is 54 years old, alive, and has a history of hypertension and hyperlipidemia. His sister is 25 years old and has mild scoliosis. His dad's mother is 78 years old, alive, with breast cancer and a history of hyperlipidemia. His dad's dad is 82 years old, alive, and has a history of anxiety, hypertension, and hyperlipidemia. His mom's mother is 70 years old with a history of lymphoma and hypertension. His mom's dad is 76 years old, alive, and has a history of COPD, hypertension, and chronic heart failure. The patient denies any allergies to medications or environmental factors, and the patient is not taking any prescription medications nor any over-the-counter vitamins or supplements. The patient denied any chills, fever, or fatigue. He denied any headaches or fainting, but admitted to ear pain to the left ear. He denied any sputum, cough, shortness of breath, or wheezing. He denied any chest pain, high blood pressure, swelling of his legs, shortness of breath, heart murmur, or rheumatic fever. He denied any abdominal pain, nausea, swallowing problems, rectal bleeding, diarrhea, constipation, heartburn, or infections. He denied any muscle stiffness. He denied any postnasal drip, allergies, or sore throat, but he did report dizziness and mild earwax to the left ear. The patient's blood pressure was 124/69, his heart rate is 54, respiratory rate is 13, temperature was 98.6 degrees Fahrenheit. He is 6'1". He weighs 218 pounds, giving him a BMI of 28.8, but looking at his stature, he is all muscular. There's no fat on him. He is an athlete, so hence the reason why his heart rate would be a little lower than the normal 60 beats per minute, and giving him the higher BMI that's more muscle than fat. The patient was awake, alert, and well developed. He was well nourished and well groomed. On the ENT section, his external inspection of the ears and nose is without scars, lesions, or masses. Otoscopic examination of external auditory canals and tympanic membranes are normal. However, there is a moderate amount of cerumen noted within bilateral external auditory canals. There was a good cone of light. Cranial nerve 8 is intact. The nasal mucosa is pink and without discharge. The septum is midline. The turbinates are not enlarged. The buccal mucosa is pink. There's no cyanosis. Dentition is good. The lips are normal color. There are no ulcers, masses, or lesions. The mucosa of the oropharynx is moist. The tongue is midline. The pharynx is without exudates, and the tonsils are not enlarged. The patient is relaxed and breathes without effort. He is not cyanotic and does not use accessory muscles with respiration. The AP diameter of the chest is normal. The chest expands symmetrically upon inspiration. The lungs are clear. There are no crackles, wheezes, bronchi, stridor, or pleural rubs. His cardiovascular rate is normal. The rhythm is regular. S1 and S2 are normal. There are no murmurs, no gallops, and there are no rubs. There are also no bruits noted. The abdomen is soft and non-tender. There is no guarding or rigidity. Bowel sounds are normal. There are no palpable masses. There are no hepatosplenomegaly. Upon inspection of his extremities and palpation of digits reveals no clubbing, cyanosis, or petechiae. There were no labs or imaging studies performed at this visit. My assessment of the patient revealed impacted cerumen to bilateral ears, even though the ear pain was only noted on that left side. My differentials included acute otitis media, mastoiditis, TMJ syndrome, and I utilized Diagnosaurus to get my differentials. The patient was prescribed Debrox ear drops, 2 drops in bilateral ears BID for 4 days. He was to come back for a lavage of his ears to clear the cerumen within 4 to 5 days. Debrox is $5.86 at Walmart. Some common reactions are local irritation and rash. Contraindications to Debrox include perforated tympanic membrane, ear surgery within 6 weeks, tympanostomy tubes, and it can also cause a superinfection with prolonged use. The patient was instructed to return immediately if symptoms worsened. However, he was instructed to return within 4 days for the lavage. He was educated to not stick anything inside the ears, including those ear swabs that he mentioned that he used, as it can cause damage or cause an even worse impaction of cerumen to the ears, and to only clean the outer ear. He was educated on the use of mineral oil drops if he wanted as an alternative, and no diagnostic testing is clinically required at this time. Some primary prevention strategies for this patient, he was educated on proper diving techniques as he was a free diver, and to only clean the outer ear with a warm cloth, to never stick anything into the ear canal. As he had mentioned, he used the Q-tip swabs to clean his ear, so he was instructed to not do that. Some secondary prevention strategies include to have an otoscopic exam at least yearly, and to seek treatment when symptoms first start to avoid serious impaction or infection. The patient was educated to immediately return if his symptoms worsened, but he also scheduled a return visit for 4 days for the lavage. If the ears could not be properly cleaned with the lavage, a consult to an EENT would be the next step in his plan of care. The current guidelines from the American Academy of Otolaryngology Head and Neck Surgery Foundation is pretty extensive, but here I've included 3. One is that clinicians need to explain the proper ear hygiene to prevent cerumen impaction. 2, clinicians should diagnose cerumen impaction when an accumulation of cerumen, as seen on otoscopy, is associated with symptoms, prevents needed assessment of the ear, or both, and that clinicians should treat or refer to a clinician who can treat the patient with cerumen impaction by utilizing either cerumenologic agents, irrigation, manual removal, with the requiring instrumentation, or a combination of any of those. According to the article by Schwartz et al., there are many implications as to why cerumen impaction should be assessed and managed appropriately. Impacted cerumen is present in 1 in 10 children and 1 in 20 adults, and more than 1/3 of the geriatric and developmentally delayed populations. About 12 million people in the United States annually seek medical care for problematic cerumen, which results in about 8 million cerumen removal procedures. Nearly $50 million was spent by Medicare in 2012 for cerumen-related products. And cerumen impaction can lead to hearing loss, tinnitus, fullness, itching, otalgia, discharge, odor, and cough. So it's important that we assess for this as healthcare providers and make sure that we do the correct treatments. The role of the nurse practitioner in a patient who has cerumen impaction should obtain a detailed history and physical to rule out any trauma, determine whether their current ear hygiene practices are appropriate. They want to assess for high-risk patients, such as patients who are taking anticoagulant therapy, patients that have an immunocompromised state, or who are also diagnosed with diabetes mellitus, if they've had prior radiation therapy to the head and neck, ear canal stenosis, extosis, non-intact tympanic membrane, as this all tailors a plan of care. Workup consists of simply otoscopic assessment. The nurse practitioners will see cerumen and will typically not be able to see will or will not be able to see the tympanic membrane based on how severe the impaction is. If the patient is determined to be a high-risk patient, as described earlier, they would need to see a specialist, or if after the treatment of irrigation or manual removal is unsuccessful, they should also be referred. Management, as described in an earlier slide, is also the nurse practitioner's responsibility. There are many different ear medications that can be utilized to soften the earwax, such as the Debrox that I explained. They can also use mineral oils. There's a wide variety of different kind of drops that can be placed in the ear, in addition to the irrigation and manual removal options. It is equally important for the nurse practitioner to educate their patients on proper ear hygiene to prevent infections or future buildup of cerumen. The ICD-10 code for bilateral ear cerumen impaction is H61.23. The CPT code is 69210. And the most important part, the reimbursement for performing a disimpaction of ear cerumen based on the First Coast Florida rates is $51.99. According to the article by Schwartz, it is mentioned that people that are mentally disabled and children have a higher incidence of cerumen impaction. So when we're dealing with these patient populations, we need to ensure we are providing appropriate and ethical care. There are several complications of performing either the irrigation or manual removal of cerumen. So the practitioners who will be performing either method should assess their patient to determine if they are candidates for either procedure or whether they are at a higher risk for developing these complications and need to be referred to an EENT specialist. Patients who are at a higher risk for developing these complications, I discussed it in an earlier slide, but they are patients who are taking anticoagulant therapy, if they have an immunocompromised state, if they're diagnosed with diabetes, if they've had any prior radiation therapy to the head or neck, if they have any ear canal stenosis, extosis, non-intact membrane. The complications of these two procedures include external otitis, vertigo, tympanic membrane perforation, otalgia, temporal bone osteomyelitis, bleeding, and laceration. So thus it's very important that practitioners who will be performing these procedures assess their patients and know their legal and ethical considerations. I chose the Watson's caring theory because I truly believe that caring is the foundation of nursing. One cannot care for a patient in any setting without being able to truly care for their patient, as cliche as that sounds. I believe that this is what gives nurse practitioners an extra edge because they actually sit and take time to listen and understand their patients because they care. With any type of ear issue, it can be scary. People see them losing their hearing, they're afraid of losing their hearing, and or they're in so much pain. And this is why it's so important to actually care for your patient who comes into the practice complaining of ear pain, as my patient did. My patient was nervous that he might get nauseous or dizzy from the irrigation. However, with education and talking to him, reassuring him, and making it known to the patient that you actually care for him, and are there for them, it put my patient at ease. We were able to perform the irrigation where we removed the Cerumen Impaction. So not only did he feel so much better afterwards, but he was happy that he did not become dizzy or nauseous, and he went on to enjoy his summer vacation in Jamaica. Now, some of the aspects of the Watson-Curing theory, I really like it. It includes caring consists of curative factors, which in turn results in the fulfillment of certain human needs. Effective caring promotes health. A caring environment is one that offers the patient to choose the best actions for themselves. A science of caring is complementary to the science of curing, and the practice of caring is central to nursing. So I spoke about the practice of caring as central to nursing. Us nurses, we're caring. That is the central focus of who we are and what we do. With caring, it complements the science of curing. So when you are able to care for your patient, it allows them to choose what best option is best for them, and it creates a good environment for the patient. When they feel good about what they're going to do and the plan of care, they're more apt to follow it, which in turn leads for better outcomes for the patients. Thank you for watching my presentation. These are the references that I utilized. The article by Desmond and colleagues was utilized with my nursing theory, and the article by Schwartz and colleagues was utilized for my clinical guidelines, as well as the current research article, as it encompassed both, and it really was an excellent read.